Good morning, everybody. We'll start the Subcommittee on Oversight and Investigation. Invite our witnesses to come to the table. I'll open with my opening statement. We convene this hearing of the Subcommittee on Oversight and Investigation today to gather information on the entity responsible for overseeing the administration's changes to the private insurance market, the Center for Consumer Information and Insurance Oversight. It's been nearly a year since the health care law was enacted, and this is the first hearing this subcommittee has had since passage of the law devoted exclusively to its effects. This center is responsible for the massive changes being made by the administration to the private insurance market. It is responsible for new insurance market rules, the temporary high-risk pools, new medical loss ratio rules, and will assist states in implementing the massive new regulatory burdens imposed by the administration. Our witnesses today are former director of the center and the current one, Mr. Jay Ingoff, who ran the office from its inception after the passage of the bill until earlier this year. We know very little about this creation of this office, and I hope this hearing this morning will finally shine some light on how this office was in fact created, how it is simply organized, and why it is recently moved from HHS to CMS on literally the day the Republicans took the majority in the 112th Congress. Just a coincidence, I'm sure. We also know little about how this office is funded. Is it paid for out of the health care law that was signed last year? Is HHS taking money from another program? So we know very little, and what we do know has not made a favorable impression on us, perhaps because we don't understand. Last year, the New York Times reported, quote, "In Bethesda, Maryland, more than 200 health regulators working on complicated insurance rules have taken over 3 floors of a suburban office building, paying almost double the market rate for the space in their rush to get started," end quote. So I hope the administration and its regulators are better at writing regulations than perhaps in writing leases. Our other witness is Mr. Steve Larson. Mr. Larson was recently promoted to director of the center and had previously served in the center's Office of Oversight, the office that was responsible for granting waivers from the Obama administration's health care. I think it is an understatement to say that these waivers have been controversial. The administration's health care plan was sold as all benefit and no downside. So when the public began hearing that while they would have to comply with all the new regulations and cost, while other individuals would get waivers from the administration and thus not have to comply and bear the same burdens, obviously they weren't happy. After all, they were promised that if they liked their coverage, they could keep it. We heard this mantra over and over again. If you like your coverage, you can keep it. They were promised lower premiums. They were promised lower cost. So simply, what did they get? Lost coverage, higher premiums, and higher cost, in our opinion. And when the damaging effects of the administration's health care plan got so bad that people were starting to notice, then it was time for waivers. The promises made by supporters of the law just simply have not come true. The chief actuary for the Center for Medicare and Medicaid Services recently testified that the law will likely not hold down costs. He went on to say that not everyone will be able to keep their coverage, even if they like it. Meanwhile, the adverse effects of the law on the private sector have been undeniable. Companies are considering dropping coverage, insurers are opting to exit from the market, and consumers are left with fewer options, in fact. And of those options available, the premiums continue to rise, thanks to the costly mandates and regulations in Obamacare. It certainly doesn't get any better when you look at how the government is handling this health care bill. Last month, this subcommittee's hearing on the need for regulatory reform highlighted how numerous regulations in the health care bill have been issued without even public comment. If an idea is controversial and lacks popular support, like end-of-life counseling, for example, then it simply sneaks into the regulations in the hope that nobody will notice. No comment period, just happens to appear. So today, my colleagues, we will hear testimony about why so many companies and insurers need to be excluded, given waivers from this great health care bill that the administration has touted. Ironically, considering that if you listen to the administration for the last 2 years, you'd wonder why anyone would ever need to be protected from this law. Yet today we have learned that over 2.5 million people have been exempted from the administration's health care plan through these waivers. 2.5 million people need to literally be protected from the devastating effects of the health care bill the administration has passed. Yes, protected. Under the very standards determining whether a waiver will be granted, a company or insurer needs to show that unless a waiver was granted, beneficiaries were either going to face a significant premium increases or a significant reduction in access to benefits. So we will hear today that these waivers are necessary because the plans they affect offer little coverage. We will likely hear at length today that the reason it is okay to give out these waivers is because in 2014, the exchanges will finally provide low-cost, quality health care. Yet nearly every promise made about Obamacare has been broken. During the debate on health care, our party offered many solutions to expand access to health care services without raising costs or bankrupting the country. They were not passed. They were ignored. So I'm hopeful today that we begin to examine the effects of the administration's health care bill. Americans from all parties, both parties, will begin to see the value in our ideas that rely on common sense and free market solutions, and perhaps not on decisions that are made by the federal bureaucracy. I'm very interested in the testimony we'll hear today because this center is responsible for many of the changes in the administration's health care bill that it makes to the private insurance market. And I hope our witnesses will shine some light on the reasons for these changes. I know this is a busy season for them, so I appreciate them coming up here, especially with the budget process and the budget being released this week. So I thank them sincerely for their time. Today marks the beginning of what the public voted for in 2010, real and sustained oversight of the federal takeover of the healthcare industry. And with that, I recognize distinguished colleague, Ms. DeGette.
Mr. Chairman, out of deference to the two hearings this morning, I'm going to defer to the ranking member to make his opening statement first.
Mr. Waxman is recognized.
Thank you very much. I am a strong believer in effective oversight. It's essential to ensure that the laws passed by the Congress are implemented in the most effective and efficient way possible, and that's why I support oversight of the Affordable Care Act. The health reform law passed by Congress, signed into law by President Obama last year, provides tremendous benefits. Insurers are banned from discriminating against children with pre-existing conditions. Seniors are already benefiting from lower drug prices. Small businesses are getting tax cuts to pay for health insurance. The law has benefits for all Americans, and we ought to be doing what we can to make sure the administration is implementing the law appropriately. But I'm concerned, Mr. Chairman, that this committee is using oversight as another means of blocking the implementation of the law. Over the last few weeks, the committee issued broad document requests to the Department of Health and Human Services that require massive document searches for no apparent purpose. Already, HHS has provided over 50,000 pages of documents in response to these requests. And already we're seeing Republican leaders make unsubstantiated allegations that wrongly accuse the Department of misconduct and mismanagement. Before they've even had the hearing and gotten the facts, Republicans are telling us that the law has failed. And I believe that it is not true. The subject of today's hearing is the formation of the HHS Center for Consumer Information and Insurance. This group within HCFA, within CMS, has provided insurers from a provision of the health care bill banning annual limits on health care coverage. The insurers are saying unless they get some of these waivers, the price of the insurance will go up before we get to the period of 2014, or the availability of the insurance will not be as much as it has been in the past. So we wrote into the law that we wanted the department to give these waivers, at least until 2014, when the law will be fully in effect. Our chairman has asserted that the granting of these waivers show that healthcare reform is flawed. Quote, "If the law is so good, why are so many waivers to the law being granted?" said Senator Orrin Hatch, who decried the lack of transparency. Oversight Chairman Darrell Issa has asserted that unions have received special treatment because, quote, "bureaucrats are picking winners and losers in a politicized environment where the winners are favored constituencies of the administration," end quote. But let's look at the facts. The waiver process has been transparent and efficient. HHS put out an interim final rule, 3 set of guidance, and worked individually with each applicant to resolve any problem with waiver requests. Over 90% of all entities that applied for waivers were approved. The average wait time for approval of a completed waiver request was only 13 days. The process has been fair. Contrary to Chairman Issa, there has been no favoritism to unions. The information HHS has provided to the committee shows that plans that serve union employees were almost 5 times as likely to have their waivers denied as non-union plans. 9 of the last 10 largest applicants to be denied waivers were plans that provided care for union members. The law and waiver process are designed to accommodate plans with low annual limits known as limited benefit plans or mini-med plans. These plans either have a set limit of dollars that they'll spend on benefits or a limited amount of benefits that may be received or a cap on specific benefits. These are plans that by 2014 will no longer be able to do what they're doing because in 2014 all plans are going to have to cover the minimum health insurance package. They will not be able to discriminate on the basis of pre-existing conditions, and consumers and small businesses will have improved access to affordable care through new health insurance exchanges. The waivers are intended to provide a smooth transition between now and 2014. They affect a small population, less than 2% of all Americans with employer-based coverage, but for this group, they provided valuable interim relief. The Democratic staff has prepared an analysis of the waiver process that documents its success, and I ask this analysis be made part of today's hearing record. I was the ranking member of the Oversight Committee when Dan Burton was chairman, and during that time, President Clinton was in office. No allegation was too wild for him not to pursue. The committee would demand thousands of documents, take up hundreds of hours of taxpayers' time in investigations that cost taxpayers millions of dollars, all with no regard for the basic facts of the case. An allegation would come out before they got the information. And then when the information came out disproving the allegation, they were already ready for another allegation. They moved one day to the next with attacks. Well, Mr. Chairman, I hope we're not going to see that go on in this committee and in this Congress. Let's be fair, let's get the facts, and let's see what the reality is before we make any of these accusations that I've been hearing. I yield back the balance of my time.
Gentleman yields back the balance of his time and recognize gentlelady from Tennessee for 2 minutes.
Thank you, Mr. Chairman. I welcome our witnesses today. We've been waiting a long time to ask you these questions that we have for you, and reading your prepared remarks, I think we would all be led to believe that this has been an unqualified success in its rollout. You talk a lot about benefits, but you don't talk a lot about expected cost, and we'll want to talk with you about that. I want to go to the waivers because there have been some 900 health plans that have been given waivers, and we will discuss those waivers as we move forward. I think we're going to want to know what happens in 2013 and 2014 when those companies are not able to get waivers. These waivers gave relief to some plans, but will happen to, we want to know what's going to happen when the other mandates of Obamacare are phased in, and it seems to me that these are 900 news stories that the administration probably is wanting to avoid because private sector plans that are working for people, they don't want to come under Obamacare. And so they are coming to you to get a waiver. In Tennessee, we've been down this costly road before, and Mr. Chairman, I have some charts on what happened in Tennessee that I would like to submit for the record. As I've repeatedly stated in this committee, TennCare gave unlimited access to care. It incentivized use rather than controlled cost. It reached the point of consuming 35.3% of the state budget. That was in 2005, nearly bankrupted the state. So I'm going to want to know, if you're using history as a guide, what is your plan for dealing with cost acceleration, which comes on you very quickly if you look at the TennCare model, which is the closest thing in this country to what you have. Even our former governor, a Democrat, Phil Bredesen, did a lot to rein in the exploding cost, implementing a program. But there again, we saw what happened in our state. I thank you, Mr. Chairman. I yield back.
And I thank the gentlelady. Recognize Dr. Burgess for 1 minute.
For 1 minute?
We're going to go 1 minute to Mr. Burgess, 1 minute to Mr. Gardner, and 1 minute to Mr. Barton.
All right.
Showed up.
Very well. Then let me just welcome our witnesses. It's good to see you again, Mr. Engoff. We had a nice visit last November. This is an issue that has been of great interest to me for quite some time. In fact, you were known by a different acronym when I met with you, and now I've followed with interest that there have been some changes within the agency, and whether those are good or bad remains to be determined. Mr. Waxman spoke eloquently of the problems that he saw in a previous Congress, but let me just allude to the problems that I saw in the last Congress when we decided to be indifferent to oversight and not even ask a simple question. We passed this law, in my opinion, in a way that was poorly done, and then your agency, within the agency, was set up with very little notice to the Congress. No one knew you were here. No one knew how much money you were spending, where it was coming from. And then we find out that in order for the Patient Protection Affordable Care Act to work, you had to give 2.5 million people waivers. Well, it doesn't sound to me like the definition of a good, solid foundation. So I'm grateful that we're doing the oversight now, grateful to the subcommittee chairman for calling this hearing. I wish we could have done this several months ago. I think it would have helped all of us. But thank you, Mr. Chairman. I'll yield back.
Thank the gentleman. And Mr. Gardner, you're recognized for 1 minute.
Thank you, Mr. Chairman, and the witnesses for attending today for convening our first hearing, oversight hearing on the Patient Protection and Affordable Care Act. A lot of promises have been made about the health care reform. Costs would be lower. People would have better access to health care. If people like their coverage, they could keep it. Those promises are not being kept. The waivers issued by HHS exempting health plans from the prohibition on annual or lifetime benefits or lifetime limits on benefits is a good case study. Over 900 health plans would have been forced to reduce benefits, raise costs to their enrollees, or drop the plans altogether because complying with the requirements of the health care bill was just too expensive. Even worse, these waivers are simply postponing reality. What will happen as other requirements of the law are phased in and health plans are not able to comply with those further financial burdens? This is why this committee's investigation of the bill is so timely in the Center for Consumer Information and Insurance Oversight. We cannot wait until the exchanges are up and running to discover that they are not working. Congress can't stick its head in the sand and deny the law of economics. Companies that need waivers today will not suddenly be able to provide even more required benefits in 2012 when the health care bill fully kicks in. Many of the assumptions that are underpinning the health care bill have proven to be false. For instance, it was estimated that 375,000 people would enroll in the high-risk pools. Instead, only 12,000 people enrolled. Recent articles in the news have discussed the increasingly unbearable burden that Medicaid places on state budgets. Medicaid is 21% of total state spending, and annual spending growth on the program doubled between 2008 and 2009. I'm excited to get to work on this, believe we've got a lot of work to do, and look forward to hearing from you before we end up bankrupting this country.
I thank my colleague and the distinguished emeritus chairman, Mr. Barton.
Excuse me. Thank you, Mr. Chairman. I'll put my formal statement in the record. Today's hearing is the first of many, but I think it is telling, Mr. Chairman, that we're here today with an oversight hearing over an organization that's not explicitly authorized in the Act, whose job is to give waivers to a law that supposedly is going to lower cost, but the very reason they're giving waivers is because the cost of complying with the law is so large that over 900 companies or 900 insurance plans have been given waivers because they could not comply if they had to honor what the law said. So this is going to be a good hearing. I appreciate each of you two gentlemen being here, and I'll try to participate some, Mr. Chairman, but as you know, we have the FCC Commission downstairs simultaneously, so some of us have to try to be two places at one time, which is not possible.
Appreciate your
Thank you, Mr. Chairman.
being
Thank
here.
our witnesses.
Thank you. The gentlelady, Ms. DeGette, is recognized.
Thank you very much, Mr. Chairman. Last year, President Obama signed into law landmark health reform legislation to improve health care access for millions of American families and small business owners, prohibit abusive insurance practices, and to reduce our nation's deficit. Today's hearing is focused on implementation of the law's prohibition on annual and lifetime limits on health care coverage, an important consumer protection that prevents people with chronic or catastrophic illnesses from losing their coverage after they reach an arbitrary cap on expenses established by their insurer. This is a provision that's already protecting consumers and will protect millions more. Individuals with chronic and expensive diseases like diabetes, and it is widely supported. Mr. Chairman, I'd like to insert into the record letters from the American Cancer Society and the American Heart Association about the importance of this provision.
By unanimous consent, so ordered.
Thank you. We are transitioning to this new policy, and millions of Americans with insurance are benefiting immediately. But a small percentage of insured Americans are in plans that will need waivers from these provisions until the health care bill takes effect in its entirety in 2014. The law allows for those waivers, which are the subject of today's hearing. And Mr. Chairman, you noted that 2.5 million people are subject to these waivers, but I would point out that's 2.5 million out of 164 million, which is less than 2% of the market. The Center for Consumer Information and Insurance Oversight is responsible for implementing the consumer protections against insurers' annual limits. CCIIO announced that that process in a public rule last summer and issued further guidance based on input from affected entities. CCIIO is granting waivers to this provision in cases where insurance providers show that compliance, quote, would result in a significant decrease in access to benefits or, quote, would significantly increase premiums. Republicans on this committee and elsewhere have made a number of allegations about this agency and its process for implementing the ban on annual limits. Senator Kyle and others have made statements suggesting that CCIIO may be providing waivers to political allies such as unions. And in fact, Mr. Chairman, you yourself have suggested that the volume of waivers granted indicates flaws in the health reform law. But the information and documents that the committee has received tell a different story. They show that the administration is implementing the law in a fair, transparent, flexible, and efficient way. The administration data shows, over 90% of applicants who sought waivers. I'm working on a cold. I'll try not to sit too close. 90% of the applicants who sought waivers for their plans received HHS approval. The average completed application was approved by HHS within 13 days, with over 1/3 approved in under 1 week. Now, this is exactly the kind of governmental efficiency that everybody across the aisle should be standing up and applauding. We reviewed emails that the companies requesting waivers exchanged with CMS. Here's, formerly HCFA, by the way. Here's what a few of the companies had to say. I want to sincerely thank HHS for working so hard to process and approve our waiver application. Quote, thanks to you and all the staff at CCIIO for your consideration and effort. Quote, we just want to thank you for the prompt and courteous service you gave these applications. Mr. Chairman, these don't sound like businesses that are overburdened and fearful of government regulation. They sound like satisfied clients. As for the claim of bias towards unions, the data received by the committee shows that the plans that serve union employees were almost 5 times more likely than average to be denied waivers. If the administration is somehow biased in favor of unions, that frankly is a pretty strange way of showing it. In the subcommittee's first hearing, we learned from the administration how the President's executive order on regulations has instructed agencies to implement laws in a manner that protects consumers while imposing the least burden possible on business. The implementation of the annual limits provision provides a case in point in how the administration is acting on those principles. The plans that are receiving waivers need improvement. They are often so-called mini-med plans that offer limited benefits. In 2014, thanks to the new health care bill, almost all Americans will get better coverage than this. But for now, these limited plans are the best coverage available for many of these workers, and the waiver process accommodates business and insurers so that consumers can retain access to these plans in bridge years. Based on clear regulation and guidance, CCIIO evaluates waiver requests on clearly explained criteria, such as premium changes in percentage terms and dollar terms, the number and type of benefits affected by the annual limits, and the number of enrollees under the plan seeking the waivers. Approvals, once granted, are rapidly posted on the HHS website. The overall process for implementing this important health reform provision and the waiver provisions within it embodies the principles that all of us on this committee seek in the regulatory process. I look forward to hearing from our 2 witnesses today. I hope we can talk about facts and why this is necessary and why it's working, and I yield back.
I thank the ranking member, and let me open up by saying I ask unanimous consent that the contents of the document binder be introduced into the record, subject to any necessary redactions by the staff. Without objection, the documents will be entered into the record. And let me address the 2 of you before we start your opening statement. You are aware that the committee is holding an investigative hearing, and when doing so has had the practice of taking testimony under oath. Do you have any objection to testifying under oath? Okay. The Chair also advises both of you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony today? Okay. In that case, if you please rise and raise your right hand, I will swear you in. Do you swear to tell the whole truth and nothing but the truth, so help you God? You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. If you'd be so kind now as to give us, each of you, your 5-minute summary of your opening statement. Thank you. Mr. Larson.
Chairman,
Thanks. I think you need to bring the mic a little closer. I think that's better.
Can you hear me now?
He can hear you good. Thank
Okay.
you. Thank you, Mr. Larson.
My full testimony has been submitted for the record. I serve as Director of the Center for Consumer Information and Insurance Oversight within CMS. Since taking on this role, I've been involved in implementing many of the provisions of the Affordable Care Act, including overseeing private health insurance reforms, establishing the health insurance exchanges, and ensuring that consumers have access to information about their rights and coverage options. Prior to becoming the Director of CCIIO, I served as the Director of the Office of Oversight within CCIIO, which works with the states to implement the new insurance market rules, including the new restrictions on annual dollar limits on health insurance benefits. As Director of CCIIO, I'm committed to improving the health insurance system so that it works for consumers now and in 2014, when consumers will have more quality health care options. I'm working to make sure that Americans who have insurance today can keep that coverage as we transition to the improved system in 2014. As part of improving the current health insurance system, the Affordable Care Act ensures that consumers are provided meaningful and reliable coverage for their premium dollars by phasing in restrictions on annual limits in insurance policies between now and 2014. This is one of the subjects that you've asked me to discuss today. Right now, over 160 million Americans get their health insurance through an employer. However, not all coverage offered by employers is the same. A very small percentage of employees are offered policies with low annual limits, caps on the amounts of benefits that are provided under the policy in a year. Often these policies are offered by employers who hire lower wage, part-time, or seasonal workers. While having such limited coverage may be better than no coverage at all, this coverage unfortunately can fail those that need it most. These policies can have high deductibles and annual dollar caps as low as $2,500. Some are better, with $5,000 or even $25,000 in coverage. But in the case of a serious illness or accident, the coverage can be inadequate. In 2014, consumers will be able to purchase fuller health insurance coverage in state-based exchanges, competitive marketplaces, where consumers and small businesses can shop for private coverage and will have the market power similar to large employers. Small businesses with fewer than 25 employees will be eligible for tax credits to help pay for their employees' coverage, and small businesses with up to 100 employees in a state will be able to join the shop exchanges. But in the time between now and 2014, we need to maintain the coverage that employees have until better options are available for them. For policies with low annual limits, immediate compliance with the new Affordable Care Act protections that restrict annual limits could cause disruption of this coverage. The Affordable Care Act directs the Secretary to implement the restrictions on annual limits in a manner that ensures continued access to coverage. This is accomplished by phasing in the annual restrictions for most policies, and for this year, we established a waiver process for the small percentage of policies that are substantially below the restricted annual limit set in the regulation. These waivers only apply to this single provision of the ACA. Insurance companies and employers that receive waivers must comply with all other parts of the Affordable Care Act. Our goal has been to implement the law, but to do so in a manner consistent with the statute and in a way that preserves employees' coverage options until 2014. All employers and insurers that offer limited benefit plans may apply for a waiver if they demonstrate that there will be a significant increase in premiums or a significant decrease in access to coverage without the waiver. Applying for a waiver is simple, a basic process that CCIIO clearly published on our website. We administer the process fairly, without regard to the type of the applicant or size of business. We published our standards for reviewing applications in the regulations implementing the law, and again in the bulletins implementing the regulations. The vast majority of waivers were granted to health plans that are employer-based, more than 95%. Of the waivers approved, 47% were to self-insured employer plans, 26% to HRAs, and 21% to Taft-Hartley plans, which are multi-employer plans governed by collective bargaining agreements, and 3% to issuers, insurance companies who provide these policies. The limited benefit plans for which waivers are allowed cover an extremely small portion of people who have employer-sponsored health plans. Since setting up the waiver program, CCIIO has granted waivers to plans covering approximately 2.4 million people out of the 150 million or so who have employer-sponsored health coverage. This is less than 2% of all covered people in the private insurance market. The vast majority of employers who applied for a waiver reacted to the application process positively. We have been open to feedback from applicants, and based on their input, we improve the application process so that it is timely and responsive to their needs. We view our work as a partnership between the federal government, states, employers, and consumers who are constantly striving to meet, and we are constantly striving to meet our stakeholders' needs. As we work to 2014, we're implementing the ACA carefully and responsibly so that coverage is maintained and the market is not disrupted. Thank you for the privilege of appearing before you, and I'd be happy to answer any questions.
Thank you, Mr. Larson. Mr. Ingoff, the opening statement. Sure.
Mr. Chairman, Madam Ranking...
I think you have to pull it a little closer, and you got the mic on, right?
Yes, sir.
Okay.
Yes, sir.
Okay, there you go.
Mr. Chairman, Madam Ranking Member, members of the committee, I appreciate the opportunity to testify here today to discuss the Department of Health and Human Services work to implement the Affordable Care Act. I currently serve as Senior Advisor to HHS Secretary Kathleen Sebelius. I also served as the Director of the Office of Consumer Information and Insurance Oversight, known as CCIIO, during its 9 months as an independent division of HHS until its recent merger into the Centers for Medicare and Medicaid Services, or CMS. CCIIO's accomplishments during that period include the following. During its first 3 months, the establishment of 2 major programs, the Pre-Existing Condition Insurance Plan and the Early Retiree Reinsurance Program, and the development and implementation of our new website, healthcare.gov. During its first 6 months, the promulgation of regulations implementing the insurance market reforms of the Affordable Care Act. Among other things, those rules now enable young adults to stay on their parents' policies till age 26. They prohibit insurers from discriminating against those under 19 with pre-existing conditions or from canceling coverage. And they eliminate lifetime limits on coverage. During its first 7 months, we implemented 3 major grant programs to states. Rate review grants, which are enabling states to establish or strengthen their capacity to review and, where appropriate, to disapprove proposed health insurance rate increases. Exchange planning grants, which are enabling states to begin the work necessary for establishing their exchanges. And consumer assistance grants, which are enabling states to develop or strengthen existing programs enabling consumers to obtain insurance and to more effectively deal with their insurance companies. By the end of 2010, the promulgation of the medical loss ratio rule and the rate review rule. Under our medical loss ratio rule, insurers in the individual and small group markets must spend at least 80 cents of the premium dollar on health care costs and quality improvement activities, and no more than 20 cents of the premium dollar on administrative expenses. Insurers that don't meet this standard must either reduce their premiums or issue rebates to their policyholders. Under the rate review rule, insurers must publicly justify proposed increases exceeding 10%, which are then reviewed for reasonableness by the state, or if the state does not review rates, by HHS. These reforms, Mr. Chairman, are already having a positive effect in the marketplace. For example, the trade press is now reporting that as a result of the medical loss ratio rule, insurance companies are streamlining their expense structures, moderating their increases, and improving their benefit packages. And more than 1.2 million adults can now remain on their parents' health insurance plans because of our dependent coverage until 26 rule, part of what we call the Patient's Bill of Rights. Most importantly, individuals are being helped. People like Kayla Holmstrom, who was in a motorcycle accident when she was 9 and has a chronic bone infection, but who's studying to become a nurse at South Dakota State University and can now stay on her parents' policy until she's 26. And people like James Howard from Katy, Texas, who has brain cancer and was canceled by his insurance company, but was able to get coverage through the PCIP program that may well have saved his life. While the American health system has always had examples of shining successes and good care if you can get it, the system has failed other citizens for too long. People with pre-existing conditions have been locked out of coverage by insurance companies. After long careers, we've told Americans to keep working until they reach the age of 65 because without a job, as a practical matter, they can't get health insurance because insurance companies surcharge them both based on their age and based on health status. We've allowed insurance companies to select out risk and to segment the market, to cherry pick the healthy and to exclude the less healthy. The Affordable Care Act, Mr. Chairman, is changing this. It's building a more equitable health care system which empowers consumers, establishes new consumer protections under the law, and gives consumers new information so they can make the best choices for themselves and their families. It's putting consumers back in control of their health care coverage by giving them an unprecedented amount of clear information on the health care market, protections that bolster the rights of consumers in dealing with insurance companies, and an innovative new marketplace. Most importantly, beginning in 2014, the Affordable Care Act will allow individuals, families, and small business owners to pool their purchasing power through new state-based exchanges in which insurers will compete based on price and quality, and people will be able to make apples-to-apples comparisons. In conclusion, Mr. Chairman, I have every confidence that the new Center for Consumer Information and Insurance Oversight within CMS will continue the vital work of the Office of Consumer Information and Insurance Oversight, and I look forward to the results it will produce. Thank you for the opportunity to appear before you today, and I'll be happy to answer any questions you or the members of the committee may have.
I thank you. I thank both of you for your opening statement. I'll open with my series of questions. The ranking member indicated the efficiency of the Obamacare and how the people who got the waivers sent thank you letters back. I would submit that's like saying to a person who won the lottery, are you happy with the efficiency of the lottery that you won? They would explicitly say yes and be glad to send a lot of thank you letters back. But having said that, Mr. Larson, I just looked through your resume and I noticed that Governor O'Malley appointed you as a member of the Maryland Health Service Cost Review Commission that actually sets the rates in the state. Is that true?
That's correct.
Are you still on that board?
No, I'm not.
When did you leave that board?
When I started with the federal government.
Okay, so I was a little concerned. I wasn't sure.
No, I'm not.
Okay, okay. Let me move to this, Mr. Larson, to this area of waivers. When we ask questions, we each have 5 minutes. So if you could just answer yes and no. And if we reach an impasse here, I'll certainly give you a little time. But I'm hopeful that you can answer most of the questions yes or no. I've been informed that that you folks are considering or have given a waiver to the entire state of Florida. Is this true?
We established a process that permits states to apply.
Not. Has the state of Florida received a waiver? Yes or no?
Yes.
Okay.
Well, may I clarify?
Oh, sure.
The process that we set up for the states essentially allows the states to apply on behalf of the issuers.
Just in curiosity, did New York State get a waiver? The entire state?
Not to my knowledge.
So only Florida. Can you list to me all the states that got a complete waiver?
Yes, I can confirm. I think it's Ohio, Tennessee, Florida, and there may be one more.
And New York City being considered? New York?
I don't believe New York applied, but I can double check.
Can I ask you this question? Has New York applied?
The state of New York?
State of New York. Our understanding they have applied.
Oh, they have applied.
Okay, New York.
But we haven't made a decision on it.
I understand, but New York has applied. Okay. So the question is, obviously, why would Florida need a waiver? Why would New York need a waiver? And all these other states, you're giving complete carte blanche for these states. You know, I think for many of us under the 10th Amendment, we believe the states should be able to come up with their own health care and perhaps handle their health insurance market better than the government. Simply tell me, why would the state of Florida, perhaps New York, and why do you think Florida needs a waiver, the entire state?
Sure, sure. So the waiver program is set up to ensure that that small percentage of employees under these small benefit policies can continue coverage. So in a small number of states, there are state programs that authorize or require these limited benefit policies. And so we made the determination to allow the states to apply on behalf of the issuers in their state.
Now the big question is, okay, all these states, you're 1 year into this and you're recognizing large states and small states, you're giving waivers. What happens in 2014? In fact, these waivers are only for 1 year, aren't they?
That's correct.
Okay, so then all these states will have to come back in the year 2013.
We made the decision for a 1-year waiver in order to gather better information about these types of policies.
If they needed a waiver in 2011, won't they need a waiver in 2012 and 13? So you'll go back and give a waiver, presumably again.
I was trying to answer. We haven't made a determination about what happens. These policies and these waivers represent a glide path, if you will, a transition to 2014. So we set them up to do the first year to gather data and then determine what the next steps would be between now and 2014.
Would it be fair to say that in year 2014, none of these people will get waivers, or will you consider giving waivers even after the exchange is in place?
In 2014, consumers will have access to full coverage, not the types of limited benefit policies that they have today. So in 2014, there won't be limited benefit policies to be waived from. Consumers will have access to the full range of benefits.
I guess the basic question was, McDonald's is a large corporation that got a waiver. Is that true?
The carrier that provides coverage to McDonald's, yes.
Got a waiver.
CCIIO.
And didn't Waffle House get a waiver?
I don't know specifically
That's how your staff
about.
is saying yes. So
Okay.
I assume you should, I would think you should know these.
Well, I haven't memorized the list of 9.
Well, some of the big ones, like McDonald's and so forth, I would think you would know.
Well, I do know about McDonald's.
Well, let me ask you, did Denny's get one?
I'd have to look at the list.
Okay. How many private corporations do you know, just offhand? A dozen or 100 or?
Well,
you got 915 that got waivers, and you said you denied 61. So out of that 915, you gave me a percent. So I guess some of the large corporations got these waivers.
When we think about the waivers, we think about the type of employers and issuers that have applied. So self-insured employers, for example,
Okay.
represent 49% of the applicants. We have
I can't resist this question. Where in the healthcare bill does the word waiver? Can you give me the specific line where it says waivers will be granted to healthcare providers in the healthcare bill? Where do you get your?
Sure. The annual limits provision of the Affordable Care Act specifically directs the Secretary to implement this provision in a way that ensures.
But the word
continued-
waiver is not in there.
I don't know whether the word.
Well, we
waiver-
couldn't find it anywhere. So you're saying your interpretation is implying that your definition of waiver is through that interpretation of the language.
To comply with the
Gotcha.
requirements of the ACA.
Okay. My time has expired. The ranking member, Mr. Gett.
Thank you very much. Mr. Larson, when you say that a waiver was given to Florida, that doesn't mean every insured person in Florida was given a waiver, correct?
That's correct.
I mean, basically what it is waivers were given to some states that had state laws that would violate the new federal law, and they were given specifically for these individual market plans within those states, correct?
Sure. States that had, yes.
So how many states did that involve?
I think we've approved 4 states to date.
4 states, and those states were approved based on their state laws that might have affected those individual plan markets, correct?
Even the applicants in the states had to still satisfy the regulatory standard for getting a waiver.
So there was no political, someone from the White House didn't call you folks up and say, you know, approve these states because it's going to be important in the election next year. I think
No,
that was
and we
the
applied the standards consistently across all applicants, whether
Thank
it's
you.
a state applicant.
Now, Mr. Larson, some have alleged that the process through which waivers to annual limits are granted lacks transparency, so I want you to walk us through the process by which your agency makes waiver decisions. Can you briefly describe the factors that you take into account when evaluating waiver requests?
Yes, and the standards were set out in the regulation that we issued subsequent to the passage of the ACA. The
Can you
standard.
briefly describe those
Sure.
standards?
So the regulatory standard requires that an applicant show that there either be a significant increase in premiums or a significant decrease in access to care. So that's the regulatory standard. We then issued subsequent guidance, I believe in November, that articulated factors that we use in evaluating those 2 standards, which include whether the compliance with the restrictions on annual limits would result in a decrease in access to benefits, looking at the policy's current annual limits. If the annual limits are particularly low, there'll be more of an impact. Looking at the change in the change in premiums in terms of percentage, and then the change in premiums in terms of absolute dollar values, and then the number and types of benefits that would be impacted by application of the law.
And is my understanding accurate that CCIIO has reached out and continues to reach out to stakeholders to make sure that you're addressing any concerns that they may have regarding the waiver process?
We do.
And in which way?
Well, we have constant interaction with the applicants as they file, and if they have issues, hopefully they're brought to my attention and we seek to resolve them. And I think, as was mentioned earlier, we have what I believe is a very positive feedback that we've received from applicants.
Now, as you described, you've put out an interim final rule and guidance on the waiver process, and about 90% of the applicants for waivers have been approved. So that would seem to me that the process is working because people understand what the criteria are and they understand how to go through the process. But there has been one concern that's been raised, and not by this committee, but by Chairman Iss's committee, the Oversight Committee. They said that you had not adequately defined some of the criteria you use in making decisions. For example, he said you hadn't published a clear, bright line numerical definition of a large premium increase. So I guess my question is it accurate that you have not published a strict numerical definition of what constitutes a large or significant premium price increase?
That's right. We do not have a...
And can you tell me why? Why not?
Sure. We took the view that applying an absolute number would not adequately allow us to fairly process the applications as they came in, because the applications in terms of the number of employees affected, in terms of their baseline premiums, they vary significantly. So for example, you could have a policy that had a very high premium but a low percent impact that actually still has a significant impact on people that pay the premium. So picking an absolute number we didn't think would be the best approach.
But just because you don't have an absolute number doesn't mean you don't have criteria, correct?
No, we do have criteria.
Thank you very much. I yield back.
Gentlelady yields back. Our next, Dr. Burgess.
Thank you, Mr. Chairman, and Mr. Engoff has already been pointed out. We have 5-minute increments in which our lives are lived. So I'm going to ask you a series of questions, and I'm going to ask us to go fairly quickly. So if we can, yes or no answers. When you came and visited me in my office, I believe it was November 30th, I had some questions then. You were kind enough to answer. We had the luxury of additional time, but today we need to go fairly quickly. So I'm going to list a number of functions that was my understanding were under your, when you were the head of CCIIO, the previous agency, that they were under your purview. So please let me know if, as I read through this list, please acknowledge that they were under your jurisdiction, or if they were not, let me know that as well. So children with pre-existing conditions?
Yes.
Healthcare.gov?
Yes.
Rescissions?
Yes.
No rescissions?
Right, the rule prohibiting rescissions.
The co-op program?
Yes.
Federal high-risk pool?
Yes, which is the same as the pre-existing condition insurance plan.
Waivers for insurance plans?
Yes.
Grandfathered regulations?
Yes.
Early retiree programs?
Yes.
Annual limits?
Yes.
Waivers for businesses?
Yes.
State exchanges?
Yes.
Coverage for children under parents' plans?
Yes.
Age 26?
Right.
And the medical loss ratio?
Yes, sir.
So all these things are functions for which you were responsible for overseeing and implementing.
Correct.
Can you help us? I've got a copy of the Patient Protection Affordable Care Act here. Can you direct us to the section of PPACA that authorizes CCIIO, to speak in acronyms for just a moment?
There is, the Secretary has discretion to manage and operate her office. But to answer your question, Congressman, there is no particular specific authorization in the bill that says there shall be created an Office of Consumer Information and Insurance Oversight. That's part of the Secretary's discretion.
So there is no authorization statute in the law that was signed by the President on March 23rd of last year?
Well, the functions are authorized. It's the specific office. There is no section of the bill which
well, what about CCIIO, the follow-on organization? Is there a section in here that I've missed that authorizes the follow-on organization? CCIIO, whatever exists today?
There is no section specifying the name OCIO or CCIIO.
Neither branch of the federal agency was specifically authorized under the legislation.
But the functions that those agencies carry out are authorized in the bill.
So when in the timeline were you hired by the administration for the purposes of creating and running CCIIO?
I was hired, I believe my first day on the job was February 16th, and
February 16th of 2010.
February 16th of 2010. The
Happy anniversary then.
oh, thank you very much. The
And I have the Federal Register from April 19th, 2010,
right, and
which talks about the Secretary organizing your agency.
yes, before you wished me a happy anniversary, I was about to say that the office was authorized on April 19th.
So March 23rd signed into law, April 19th Federal Register. Within a month of passage, the administration realized that they needed and the legislation lacked, and they were able to divert funds to hire you, create CCIIO, and do this whole creation basically out of thin air, out of whole cloth, because it wasn't authorized in statute.
Well, obviously, I wouldn't agree with that characterization.
Well, okay, well, what about, this is pretty simple then, where did the money come from? Where was the funding for CCIIO?
Yeah, the money came from the $1 billion that was appropriated as part of the ACA, and then in addition, there are certain statutes, certain provisions of the Affordable Care Act which carried with them funding to carry out those particular provisions.
So would a correct characterization be you were able to skim money off, say, some other areas, like the money for the high-risk pools, to fund your organization?
No, that's not a characterization, and that's not an accurate characterization because, for this reason.
Perhaps you'd be able to provide to the committee a detailed budget of where the money came from, the $1 million initial authorization, but there were other agencies making draws on that as well. Presumably you had, at the end, the day your agency merged into another one, how many employees were working for you?
252.
All right, that's not inexpensive to hire 252 people in Washington or Maryland.
No, if I could just go back, though, Congressman, just to one point, because I think it's very important to realize that the Act has certain sections which carry with it specific appropriations for those sections.
Let me just ask you very briefly, do you have, and can you produce for the committee, a delegation of authority from the Secretary of HHS that we can use to better understand what your services were at CCIIO?
Yes, there was such a delegation, and I'm happy to produce it.
All right. I'll yield back. Thank you, Mr. Chairman.
Thank you, gentlemen. Gentleman from Michigan, Mr. Dingell, is recognized for 5 minutes.
Thank you, Mr. Chairman. Please respond yes or no to these questions if you can. And if the answer is no, would you also please submit a detailed explanation for the record? 1, the underlying goal of the Affordable Care Act was to provide affordable quality health care for all. Do you believe the limited benefit plans provide that quality and that they provide comprehensive care to consumers? Yes or no?
No.
Okay. Next, we know that millions of Americans do rely on limited benefit plans. Do you believe consumers have been adequately informed about the benefit limits under these plans? Yes or no?
No.
The waivers are for how long? Only for 1 year, right?
Yes, sir.
And they will be reviewed at the end of that year?
Yes, sir.
So you will have the chance to reissue the waiver or to deny the waiver at that particular time.
That's correct.
This is a transitional step, is it not?
Yes, it is.
And the purpose is to see to it that you don't take away from the recipients of the benefits under these plans the benefits that they're receiving while you set up the larger plan as required by the statute. Is that right?
That's exactly right.
Now, under ACA, the Secretary has authority to determine what is restricted annual limits and the responsibility to also protect consumer access to essential health benefits. We know that without an appropriate transition time, some states, employers, and insurers would be unable to comply with the no annual limits provision and without an adverse impact on coverage or premiums. Is that correct?
Yes, sir.
Do you believe that waivers are necessary to provide an uninterrupted, affordable transition coverage to individuals?
I do.
And you will be reviewing these matters as we move towards 2014 and the full statute goes into effect. Is that
That's correct.
Is that right? Do you believe that the necessary guidance and assistance from the CCIIO has been readily available and accessible to assist potential applicants in completing the waiver application process? Yes or no?
Yes.
Do you believe that CCIIO has dedicated an adequate amount of staff time to being responsive to potential applicants regarding the waiver application process? Yes or no?
I do.
And you have put considerable effort into seeing to it that those resources are available for that purpose.
Yes, we have.
Do you believe that the waiver process has provided an ample and an adequate transition time for employers and employees to comply with the Affordable Care Act? Yes.
Yes, sir.
And that, of course, is, again, one of the purposes of the waiver provisions. And
Yes,
the
it
waivers
is.
are being granted. Is that right?
Yes, it is.
Now, do you believe that the enrollees will receive greater information about the limited benefits in their health plan under the waiver process?
I do.
Now, let's try and summarize. We are moving towards the establishment of the national plan, which takes place in about 2014. It's a very complicated, this is going to be a very complicated exercise and a complicated plan. You will be reviewing these waivers periodically to see to it that they further your purposes and the purposes of the statute in getting us where we can have a good, workable national plan which provide an orderly transition to that. Is that correct?
That's correct.
Now, if you did not grant these waivers, what would be the practical result? As I read it, you would be kicking all these people off their plans. They would receive no benefits. And so we would have a very large problem of a lot of people not receiving any coverage at all. Is that correct?
Yes, it is.
The plans are a lot of these plans are subject to criticism on the adequacy of the benefits provided, but nonetheless, that is better than having no plans to cover these people, which could happen if you did not give the waiver. Is that correct?
That's true.
Mr. Chairman, I note that I have 18 seconds to yield back. Thank you.
I thank the gentleman, and next we'll go to Mr. Murphy.
Thank you, Mr. Chairman, and welcome here. The Institute of Medicine has been asked by HHS to make recommendations on the criteria and methods for determining and updating the essential health benefits package called for by the Affordable Care Act. You know, Congress did not call for a definition of medical necessity in the bill. Well, the House bill included a definition. It's not included in the final bill as amended. But as I understand it, Health and Human Services has asked the Institute of Medicine to review definitions and applications of medical necessity, which we didn't call for in the Affordable Care Act, and is outside the scope of defining essential benefits. Can you tell me what authority does HHS believe it has to include this in the definition of essential health benefits? Either one.
Well, I can try and answer that. I apologize. I know that the Institute of Medicine has been tasked with helping HHS define what essential benefits are, and that will also be supplemented with a study by the Department of Labor. I have to confess I'm not familiar with the medical necessity component of the task that has been asked, so I can follow up with
you. Can you do that? I'd really appreciate it if you would
yeah.
follow up. That'd be great.
We'll
Thank you.
that.
Now I want to ask a little bit more about these waivers. One of the waivers from the state of Ohio, my neighbor in Pennsylvania, and it's interesting, a statement from Mary Jo Hudson, who's the director of the Ohio Department of Insurance, was this. She said, quote, "Not allowing a blanket waiver for all companies for basic and standard open enrollment and group conversion options would lead to an unlevel playing field. Some companies will seek waivers while others won't." I think that's a good point, but how are you sure you haven't created some sort of an unlevel playing field? And are you sure everyone affected by the bill will, the annual limits, know that they can apply for a waiver?
Yes, thank you. And I don't think we have created an unlevel playing field. There are a small number of states that, through state policy, have encouraged or required insurance companies to offer these, you know, as we call them, mini-med policies, in order to make sure that there's a policy available for some people who otherwise couldn't afford coverage. And in establishing the waiver process, and particularly the state process, we did want to make sure that people who have that coverage today can continue that coverage. So we set up a process that allows for the states, when there is a state policy or law or program that requires carriers or establishes a program that offers these types of mini-med policies.
But it still is a situation. The question is everybody well informed? Are you comfortable with how people are informed that they can apply for waivers and they understand the terms and conditions of which they can obtain a waiver?
We are. I mean, again, I think we've been very transparent in publicizing this. The states are aware of it. We've worked through a number of different outside entities and trade groups and the NAIC to make sure that the word got out that there was an option to apply for these types of waivers.
How about a medical loss ratio? A number of states have applied for things: Georgia, Iowa, Maine, South Carolina, Texas, et cetera, all requesting waivers for the medical loss ratio. Have any of the states contacted you about waivers for the MLR?
I would answer that in two ways. Before the medical loss ratio regulation was issued in December, we received a number of letters from states because the statute contemplates a state-based waiver process, but we hadn't set up the process yet. So we did receive letters from states before the regulations were issued. Since the regulations were issued in December that lay out the process for applying, I believe we received 3 states.
Would you let us know all the states that have that under, and what standards would a state obtain a exemption for?
Sure. Well, the standards are set out in the regulation that we issued in December.
Make sure we know that.
Yeah.
The other thing I want to know is, with the waivers that are being granted on multiple levels, has anyone done an economic or financial analysis of what this means in terms of the overall financial stability or instability, whatever, of the entire healthcare package here? Would either of you know what it is?
I'm not familiar with the study that looks at the impact of waivers.
And the issue being that if someone is required to participate, but then they're waived from that, I don't know what this actually means in terms of revenues spent, revenues locked in. We're trying to get a handle on what all this means in the whole financial analysis of this bill, and not clear if anybody's doing that analysis.
Well, in the transition between now and 2014, I think these limited waivers are beneficial to all the stakeholders, both either the companies or the issuers or the states or the beneficiaries, so that they can, continue the coverage between now and 2014.
Thank you very much.
Gentleman yields back the balance of his time. Okay. Mr. Green is recognized for 5 minutes.
Thank you, Mr. Chairman. Annual limits or coverage, as we understand it, can be a pretty rotten deal if you're really ill, and for consumers. You pay premiums for many years, and then all of a sudden you find out that your wife has cancer, or maybe your child that was just born has some terrible illness that you have to have a lot of health care for, and your insurance company ends up paying a lot, and then they end up hitting up against that annual limit, and sometimes even a lifetime limit. Unfortunately, until health care law was implemented, will be implemented in 2014, there are some people who have a choice between a plan with low annual limits on coverage or no coverage at all. And Congress intended to make that sure that people enrolled in these plans wouldn't see their premiums rise dramatically or see their options for coverage disappear while employers adjust to new consumer protection rules and the full range of health care reforms. Mr. Larson, am I correct that the waiver process we're talking about today was envisioned by Congress and put into place to help consumers in these low-cost and low-benefit plans?
That's correct.
It's my understanding that these waivers are temporary and that they're only last for a year and they won't be available in 2014 or after. Is that correct?
That's correct.
Mr. Larson, what are some of the benefits that will be available to low-wage workers once the annual limit ban becomes firm in 2014?
Well, the entire landscape changes to the benefit of the consumers. So they'll have access to an insurance marketplace. There'll be increased competition. Benefits will be fuller. There'll be premium subsidies available for individuals who can't afford to purchase insurance. But the insurance that they purchase will now have full coverage and not the restricted limits that unfortunately some people have today.
Okay. The waiver process, I know, benefits businesses too. Health and Human Services is implementing the ban on annual limits incrementally, starting with a floor of $750,000 in coverage for essential care annually, and raising that floor gradually until annual limits are eventually prohibited. Business and health plans would see substantially higher exposure to claims under even this incremental approach can apply for short-term waivers. What percentage of the businesses that have applied for these short-term waivers and received them?
Well, we approve the vast majority of the applicants that come in. Some are Taft-Hartley plans, some are self-insured businesses, some are issuers. But overall, I think the approval rate is about 95% or so.
Yeah, that's what our staff has come up with, about 90%. So, and these are requests from businesses who are asking for that short-term waiver so they can grow into the health care.
That's right.
It seems to me the waiver process implemented is just a sort of thoughtful approach that we want in a health insurance reform plan. The President advocated the ban on annual limits is a critical consumer protection, and the waiver process allows the administration to implement that protection with due regard to their individual circumstances and individual particular consumers and businesses. Prohibiting annual limits is important reform that responds to one of the worst features of our insurance market today. And again, I served 20 years in the legislature, and I understand what happens in legislatures where you have very low limit policies because you hope sometimes somebody has one, just has a policy. Annual limits can leave consumers, particularly those with expensive and chronic conditions and those who experience catastrophic medical events, with enormous medical debt and without an ability to access to health care. Congress included a ban on annual limits in the reform bill, but it also gave HHS the authority to waive it. It's my understanding that this waiver process is necessary to ensure that a small number of people in certain low-cost, low-benefit plans, often called mini-meds, would still have access at least to some coverage before health care reform is fully implemented. Is that your understanding, Mr. Larson?
That's right.
Since this waiver process does not represent a flaw in the health care law, but rather a recognition that flexibility and accommodation of unique circumstances, you don't turn around a battleship or an aircraft carrier immediately, just like you don't turn around our health care plan. Under circumstances will be required, we build towards full range of consumer protections, and benefits will be available to all Americans in 2014. Is that correct?
That's correct.
In fact, the waiver process responds to a relatively uncommon set of circumstances. What percentage of the people in private insurance plans, Mr. Larson, are covered by plans that have received a waiver?
Well, again, the number's about 2.5, so less than 2% of people that have employer-based coverage are in plans that have received a waiver.
So we're addressing this problem, but less than 2%
That's right.
have requested or received a waiver. Compared to the number of people receiving protection against annual limits under the Affordable Care Act, I'd call that number a very small amount. I wish we didn't have to issue any waivers from this important protection, but just over 1 or 2% seems fairly minor. In addition, the annual limit restrictions are but one important part of the series of protections that have been implemented since enactment. Young adults can now stay on their parents' policies till 26. Lifetime limits have been eliminated. Plans must cover preventative care for free. Mr. Larson, are any of these protections, or any of those protections being waived?
No. No, sir.
Okay. So the core protections of the law continue to be implemented smoothly with benefits for families, employers in this area. Is that correct?
That's correct.
Okay. Thank you, Mr. Chairman. I'll yield back my time.
All right. Thank the gentleman. Gentlelady, Mrs. Myrick is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you both for being here. The Center contains the Office of Insurance Programs that will administer the temporary high-risk pool program called Pre-Existing Condition Insurance Plan. The health care law created this program with $5 billion in funding, correct? I guess these probably go to Mr. Larson since you're the head of that right now.
Yeah, I'll come out and hall.
Correct?
I can speak somewhat, and Jay can as well.
Okay. Well, whoever wants
Sure.
to answer, go ahead, okay? Is it, the $5 billion is correct, right?
Yes.
Correct.
Well, and HHS recently announced the enrollment in the program. What was the number?
Approximately 12,000.
12,000, which seems awfully low considering the fact that this pre-existing condition was used routinely as one of the reasons that we needed to have the law. So don't you think the healthcare law's unprecedented intrusion into the healthcare sector was probably oversold by continuing referencing those who had pre-existing conditions?
No, I don't think so, Congresswoman. And I don't think it's low. The program's only been up for a couple of months. It's a transitional mechanism. It's only necessary because under current law, insurance companies are permitted to exclude people based on health status and to charge more based on health
Well,
status.
when the report was issued last April, CMS Chief Actuary said the creation of a national high-risk insurance pool will result in roughly 375,000 people getting coverage in 2010, and if only 12,000 have enrolled, it seems to me that that's an overestimate of about 360,000 people for last year.
No question that prediction has proved to be inaccurate. There were fears that the program would be overrun, and that's not occurred.
Well, the Washington Post did a story also on the end of 2010 in December. It's an open question whether this is what they said, it's an open question whether the $5 billion allotted by Congress to start up the plans will be sufficient. Do you think these high-risk pools will need additional funding?
No, I don't.
The same news article states New Hampshire's plan has only about 80 members, but they already have spent nearly double the $650,000 the state was allotted. Is this true?
No, it's not. They've spent more than the amount that was allotted for 1 year, but they're well under the amount that was allotted for the entire lifetime of the program.
And how many people are they scheduled to enroll then in the program?
I'm sorry?
How many people are they scheduled to enroll in the program based on what you're saying?
I can't give you a projected number of people, but I do know that the projections are that they will not exceed the amount that they've been allotted for the entire lifetime of the program.
Will states like New Hampshire be provided any more money then in case they do?
There is a process pursuant to which money could be reallocated, but
Does that mean reallocated from other states that aren't spending it, or?
Yeah, yes, but that is very unlikely because there is no state which has spent more than its allocation for the period of
at this point
that the program will be in place. And as you pointed out, there's a lot of money left to insure a lot of people, and we're looking forward to doing that.
The article also states that although they collect enrollment data monthly, you've decided to report it on a quarterly basis. Can you commit to reporting it on a monthly basis instead of quarterly? Since the data is available?
I'd have to go back and check with our systems folks.
Would you do that?
Sure.
Because it seems like, if it's overestimated enrollment, that's still spending more than it was originally promised. If you wait on the quarterly data instead of doing it monthly, it just doesn't serve the purpose, and it technically kind of eliminates political damage.
Well, we can do that. And to Mr. Engoff's point, the initial period, the startup, getting this set up was where the resources were devoted to make sure that the program was up and running.
Okay.
So we understand that there are estimates out there that are higher than the 12. We know, for example, that after we got the program up and running and we've started the outreach, I think in the last period, enrollment has increased 50%. So we're already seeing a very rapid rise in the enrollment of this, and we fully expect that to grow as we now, having stood the program up, have the opportunity to get the word.
Got one more question because I'm running out of time. HHS recently announced that new resources will be available to increase awareness of the program, correct?
Correct.
And so some of those include working with the U.S. Social Security Administration on a comprehensive outreach campaign. Any idea on the cost of that?
I don't sitting here today, but I will get that information.
If you would get it back to me.
Absolutely.
I mean, there's already been so much discussion about this health care bill, and there's been so much awareness, et cetera, over the long period we debated it, that my concern is, do we really need to spend more dollars right now on additional outreach? So, Mr. Chairman, go ahead.
I think we've learned that it really takes a lot of efforts. Many of these people are they've had a tough time. They have medical conditions. They don't have coverage. So we're going to work with hospitals and providers and other sources to make sure that they get what they need and they're aware of this program.
Thanks. I'm out of time.
Thank the gentlelady. Ms. Schakowsky is recognized for 5 minutes. Oh, Mr. Waxman, I didn't see you. Yes.
Thank you very much, Mr. Chairman. Republicans, some of the Republicans on this committee and elsewhere have been relentless in their attacks on the health care bill generally and on your office's implementation of the bill in particular. One of the main allegations is that CCIIO has acted with bias in granting waivers to annual limits on essential benefits coverage. Representative Gingrey alleged that the waiver process has been, quote, highly political and selective, and that politics and insider status, rather than objective criteria, have been guiding this process. Others have suggested that an increase in waiver grants following the November 2010 election reflects potential reward of political allies. Subcommittee Chairman Stearns said, quote, "From December 2010 to January 2011, the number of waivers grew from 222 to over 700. And yes, a lot of those waivers are going to unions," end quote. Mr. Larson, before this hearing, HHS turned over to the committee detailed information on all approvals and denials of requests for waivers from the new annual limits provisions of the Affordable Care Act. I'd like to get your thoughts on what this information shows about the allegations of bias. The information HHS has provided the committee shows that of applications by union plans or plans that serve union members, 14% were denied waivers compared to a denial rate of about 3% for all other applicants. So plans that serve union members are almost 5 times as likely to be denied waivers as other applicants. Do you think this information supports allegations that CCIIO is showing favoritism toward unions?
No, it doesn't. And to be clear, we didn't solicit applications from any particular sector. We didn't favor applicants from any particular sector or type of applicant. I know it's been described in some cases as a high percentage of union approvals, but as I think the data show, and hopefully we've clarified for you all, those are generally the Taft-Hartley plans, which in fact is employer-sponsored coverage. They're not union plans. And so as you point out, there's a small percentage, in fact, of unions that have gotten waivers, a much higher percentage of employer-based coverage.
I guess to say that unions are getting special treatment, which they're not, is a way to get people angry because of they want to stir up hostility to unions, although unions unfortunately are shrinking to less and less an important part of our economy. Mr. Larson, the information received from our committee indicates that there was a spike in waiver grants in January of this year. Can you explain why there was such an increase?
Yes. So we require applicants to submit their request 30 days in advance of the plan year, the policy year for which the coverage takes effect. And because many plan and policy years begin on January 1st, as you might expect, right around December 1st and the end of November, we received an increase in the number of waiver applications to coincide with the large number of plans. So there's kind of a bubble, and things have receded back down closer to the levels that we saw right before December.
Well, let me be very specific. I want to ask you this question. Is political support for the Obama administration a factor in any way for the CCIIO considering evaluating applications for waivers to annual limits?
No, not in any way.
And can you assure this committee that your office has handled the waiver process in an unbiased fashion?
We handle the applications in an unbiased fashion.
So when people make these charges, there's no basis for these charges. They're all political. It's all propaganda. It's just another attack on this administration, another attack on the health care bill. Well, I'm a strong believer in effective oversight, but this rhetoric and tone surrounding the attacks on HHS implementation of the health care law has me very concerned. Opponents have hurled one accusation after another at HHS and at the health care bill. And then when the facts emerge, the allegation turns out to be unfounded. I hope that we're not going to do this in oversight on all the issues that we have before us. You know, I just hear these statements that I know are untrue. The Republicans say that they had a bill that would have accomplished all the same things that the Democratic bill would have accomplished. It would have stopped discrimination for pre-existing conditions. It would have stopped these discriminations by insurance companies. That isn't what they proposed at all, and they didn't propose anything that covered Americans. Maybe 3 million, not the 30 million that the bill covered. I just get frustrated that we have to run after the falsehoods with truth. I yield back the balance of my time.
Gentlelady from Tennessee, recognized for 5 minutes.
Thank you, Mr. Chairman. And we're talking so much about the waivers that states are getting, including Tennessee, which came to you and asked for a waiver. And I've got their waiver letter with me. This came to you September 17th, 2010. This was during the administration of Governor Bredesen, who has since left office, and we have Governor Haslam. But talking about these waivers and our concern, our program in Tennessee, Cover 10, which is an innovative program that was put in place, and we're concerned about what's going to happen with these programs in the future. And I want to read from you page 6 of this letter that went to you. It says that absent a waiver, absent getting a waiver from you from Obamacare, that the state would have to disenroll 20,000 Tennesseans who were not served by the commercial market in Tennessee prior to their enrollment in Cover 10. It seems likely that the majority of these individuals would become uninsured. And finally, it goes on and states that insurance premiums would go up, get this, 86%. 86%. So would you agree with me that this would be a significant cost increase to individuals and the state?
I would. I'd just like to make one thing clear, though, that I don't think has been made clear, which is this. The waivers are not granted to states. They are granted for coverage that is mandated by states. I'm not as familiar with Tennessee as I am with New Jersey, where I was deputy commissioner. And in New Jersey, for example, New Jersey mandates that all carriers sell certain coverage.
That's right. You all had guaranteed issue in New Jersey, but we have a TennCare program that was put up as an executive order of the governor and then has been run under the purview of CMS. Okay, but you all granted Tennessee a waiver for this program, right?
For that specific program.
For the Cover 10
everything
program.
in the state,
That's exactly right.
program.
A program that is working
Right.
and providing coverage and is successful.
Correct.
Now, what is Tennessee and what are these Tennesseans going to do in 2014? Where are they going to go? What's going to happen? Because that program's not going to be there unless you give it another waiver.
Well, I just say this, there's a when a state, and we've been very conscious of this, when a state mandates certain coverage, and I'll refer to New Jersey again because I'm most familiar with that, New Jersey mandates that carriers sell relatively limited coverage. And so when a state mandates certain coverage...
Sir, I'm going to interrupt you with that because I'm not talking about guaranteed issue. I'm talking about an innovative program in Tennessee that is working and what is going to happen with that program. And see, I think my state is a great example of what is wrong with your approach to this with Obamacare. Because you're going to take away a program that is working and then people are going to be left to go through and try to find something through an exchange, and they're going to face higher rates and they're going to face a cramped access to health care services. Their insurance cost goes up and the delivery costs go up. It goes up on two fronts. Two separate fronts. You know, and I think that the letters, I was looking at page 3 of this where it defines the benefits. This is a state solution. Cover 10 is a state solution to provide affordable basic health insurance for small businesses, the self-employed, and the recently unemployed that covers the most frequently used services. This letter also explains to you that because of the way this program was set up, and the letter came to you from the Department of Finance and Administration from the state of Tennessee on behalf of the Cover 10 program. But it states this plan has seen enrollment climb because, number one, the plan is affordable and the medical loss ratio for 2010 was 87%. Now, under the current rules, this plan would disappear in 2014. Is that not correct?
Congressman, if I could respond, I actually think we're in agreement on many issues. The state of Tennessee, like other states, in response to the very broken marketplace that we're all trying to solve.
Our marketplace was broken because of the implementation of TennCare that ate up 35.3% of the budget.
I can't speak to TennCare.
And saw hundreds of thousands of Tennesseans disenrolled from the program.
So Tennessee...
You're correct. We were under the 1115 waiver program, and it did nearly bankrupt the state. And I would like to move on to my last question. No, sir, I've got one last question that I'm going to ask, and because you all avoid it. If history is a guide, what in heaven's name are you going to do with escalating cost? TennCare's cost quadrupled. They quadrupled within about a 5-year period of time. So if history is a guide, and that happens with Obamacare, I would love to hear what is your plan for dealing with accelerated cost?
Yeah.
The Affordable Care Act, in fact, is full, and its purpose is to lower the cost curve. And there's a series
Sir, history tells you that when you go into this premise of near-term expenses banking on long-term savings, it doesn't work. What is your plan B?
The plan is the Affordable Care Act. That's the plan, and it's going to work.
Sir, there is no case in history in this country where this has worked.
This will work.
Mr. Chairman,
I think
it is
the young lady, the time has expired, and we'll recognize
Mr. Chairman, I'd like to ask unanimous consent to let Mr. Larson answer the very important question that Ms. Blackburn asked.
I think Mr. Larson answered it. He said that the answer is Obamacare.
No, the previous question that she asked. That
Mr. Larson, did you answer her previous question?
Well, the only point I was trying to make about the state programs, and the point that I think we were in agreement on, which was the market is broken. People can't get coverage, haven't been able to get affordable coverage. One response at the state level, these are the states that applied for waivers, were to set up programs that have limited benefits. And we understand that. We agree that those programs between now and 2014 should continue so that those people do have access to care. And then in 2014, they will have access to much better
We'll advise all members we're going to have a second round here, so if anybody wants to stay, they can go into it. So, Ms. Jancikowski.
Well, let me explore that a little further. The waiver that is granted to states like Tennessee and Florida is to allow the mini-med plans. Talk about those plans for a minute that Ms. Blackburn has lauded as some really great coverage. What are we really talking about in terms of mini-med plans? Are they not limited coverage?
They are limited coverage. They're not all the same. Some have very low annual limits. Some have restrictions on other types of benefits. And that's the dilemma, because they're not good coverage. They don't provide comprehensive coverage. But nonetheless, today, until the full reforms of the Affordable Care Act kick in, that is an option for people. And we want people to have that option, even though it's not necessarily full coverage.
So we see that as a bridge, as you said, to better coverage. Would you describe what happens to people who are in the mini-med programs now once the full implementation of the Affordable Care Act in 2014?
Well, they're going to get a much richer, fuller benefit package, and they're not going to have to worry about whether they spend 4 days in the hospital and run out of their inpatient coverage because there's an annual limit on their policy. So consumers are going to be better off. The system is going to be better off because we're not going to have levels of uncompensated care that we have today. So that's the world in 2014.
I want to go back to the issue of the states for just a second, the overall policy, because again, it seemed to be promoted by our chairman as again the something political about Florida or New York. What is the feature in the states that would uniquely make them eligible for a waiver?
The feature is if they have a law or program that establishes a package of benefits that insurers have to issue or insurers issue pursuant to a state program. So there's a small number of states that have these types of programs, one of which is...
These are the limited benefit programs.
That's right.
Uh-huh. So
otherwise, we apply the same regulatory criteria that we apply to all applicants to the states that apply. So there has to be a significant increase in premiums or decrease in access to benefits if they had to comply with the law.
Okay. The other issue I wanted to deal with, there was a charge made somehow that there is skimming in order to create your office. And I wanted to talk a little bit about it. Mr. Angoff, I wanted to ask you about the Secretary's authority to create the office. Implementing landmark health insurance reform, of course, is a huge job. And following the enactment of the Affordable Care Act, Secretary Sebelius established the Office for Consumer Information and Insurance Oversight. So you have, I think you talked a little bit about the responsibilities of the office, but I'm more interested in getting to the question really of the authority, because Representative Burgess questioned that authority. The committee looked into, the staff did some research and found that according to the department's reorganization plan from 1953, the Secretary, quote, may from time to time make some provisions as the Secretary deems appropriate, authorizing the performance of any of the functions of the Secretary by any other officer or by any agency or employee of the department. So it looks, Mr. Angoff, like the Secretary has had that power for nearly 60 years.
That's correct. There's no question about the Secretary's authority to create the office. She has such authority.
Now, I also want to clarify what you said. You were saying that there is money in the bill to implement the provisions, and that a decision was made about a structure to do that. Taking money already in the bill, is that what you were saying, to create an appropriate structure?
That's correct. There's $1 billion appropriated for the ACA as part of the act, and then in addition, there are specific provisions, such as the provision authorizing the high-risk pools and the provision authorizing the early retiree reinsurance program, which carry independent funding with those provisions.
Thank you. So I just want to end by saying words like skim, I think, are very loaded. They create a very negative feeling that, in fact, all of the money to create this office to help implement the bill was appropriated and in the legislation. Thank you.
Thank you, gentlelady. Is the word fungible work better? Mr. Griffin, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I am curious, following up on that line, you were hired on February 16th, but the legislation wasn't passed until March 23rd. Why not put a line in there that specifically stated that you all were going to have this office?
I don't, that's not for me to answer.
Well, but it would have made things a lot clearer, would it not?
No, I don't think so. I mean, I think the provisions which Congresswoman Schakowsky cited make it clear that there's never been any question about the Secretary's authority to delegate authority and manage her jurisdiction in the way she sees fit. So I just don't see any issue there.
Do you know how much money you all spent in this endeavor? 252 employees, and I understand you had offices in Maryland at one time.
Yes, I know. For fiscal 2010, $33.4 million is the amount that comes out of the billion that was authorized, that was appropriated.
And how much do you anticipate going forward?
That would be Mr. Larson's area.
We're still working through the 2011 number, so I can't give you that number at this point. I know for in the President's budget in 2012, we've got, I think, $94 million for oversight and consumer assistance and functions like that in the President's budget.
And you indicated that, speaking to Mr. Larson now, you indicated that you had an outreach program for folks to get into the programs regarding high risk or areas where people were.
We're starting that up now. We have not to date have had a very vigorous outreach program, and I think that accounts for the lower than anticipated enrollment. So we are going to.
My question then would be, do you also have an outreach program for micro employers, people that have, you know, less than five or less employees? Do you have an outreach program to let them know about how they can easily access the ability to get a waiver if they need one?
We don't have a specific program targeted to types of employers, but I'd be happy to talk to you about ideas for doing that.
And as we go forward, you don't anticipate there being any waivers after 2014?
We don't, because the law wouldn't allow for limited waiver policies, because the restrictions on annual limits are complete at that point, and that's the point at which consumers have access to a full array of benefits.
All right. And in regard to the minimum essential coverage penalty, how do you see, you answered earlier your plan B was this is actually going to work and so forth, but how do you anticipate dealing with states like Virginia where it's been ruled unconstitutional because of that penalty, and the 26 states were in the Florida legislation, but Virginia, of course, had its own opinion? How do you all plan to deal with that? Are you going to continue to charge forward, notwithstanding the legal question, which obviously is very serious, with I think now 27 states having a ruling that says that provision at least is unconstitutional? Now the difference, of course, Virginia not only had a separate piece of legislation, but had a separate suit from the others and focused entirely on that one part of it. But how do you plan to go forward?
Yeah, I guess I would answer in two ways. First, today, right now, we're proceeding with implementation of the law, but our lawyers at HHS are, as you can imagine, looking at the implications of the ruling and how we'll be responding to that. So,
and I guess my question is that what's the plan B if ultimately the 27 states that have already gotten a ruling that it's unconstitutional prevail?
Yeah, well, that I can't speak to.
Does the plan work without mandatory purchase?
Well, I think, as discussed publicly, the individual responsibility provisions are an important part of the architecture of the ACA. But in terms of what happens, I can't get into.
Including the penalty provision?
I can't get into what happens in light of the pending litigation that we have.
So there is no plan B?
I'm not saying there is or isn't a plan B, but in matters relating to the litigation that we have with the states, we're proceeding with implementation today as I sit here, and I'll leave it to the lawyers to figure out what.
Can you let me know when you develop a plan B?
We absolutely will.
Thank you.
Thank you, gentlemen. Mr. Scalise, the gentleman from Louisiana, is recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate you calling this hearing. Obviously, we are trying to get as much information as we can about the impacts, unfortunately, in many cases, the devastating impacts of President Obama's health care law that are now being felt. I want to talk to you first about the child-only policies. We've been seeing a number of companies that used to offer child-only policies that are now getting out of the market because of this law. Are you aware, first of all, of that problem of the companies that are just dropping this line of business altogether?
Well, the Affordable Care Act set up a system where for the first time insurance companies aren't going to be able to deny care for sick kids. And that was the goal of the Affordable Care Act. And it's unfortunate, frankly, that there are insurance companies that have decided that if they can, unless they can only insure healthy kids, they're not going to offer.
So what you're saying, you are aware that there are companies now that just aren't offering these health care options to any parents who want to provide this for their children.
In the small segment of the market, there are.
Can you tell me how many companies have gotten out of this line of business since these?
Oh, I can't answer that exact question. I don't know.
I mean, I would understand it's your job, your office's job, to follow these effects on insurance industry and ability for people to get access to health care. I would think it's your job, so I would think you know how many.
Here's what we've done. We've provided guidance to states, Louisiana and other states, with a range of options to encourage them to take in order to maintain a market for these carriers that otherwise don't want to insure sick kids. So they're leaving the market because unless they can just insure healthy people.
Right, and one of our concerns all along, and I mean, frankly, it was discussed by those of us on this side of the aisle when this bill was being debated over the course of the last year and a half, that these kinds of mandates and laws that were included in Obamacare were going to deny access to people who had health care that they liked. And of course, the president multiple times would say, if you like what you have, you can keep it. And we pointed out in many cases that because of these changes, they were going to actually force a lot of people just out of the market altogether, which would deny coverage to many people who had health care that they liked. And so I mean, you don't know the number of companies now, you're saying that. I would encourage you to go and find out how many there are and find out what things need to be done to unravel it, unless I guess y'all are more concerned about invoking a policy than actually improving access to people who want to get health care, because your policies that took effect, I see, in September of 2010 are what ran a lot of these people out of the market altogether. And there are articles that started coincidentally right after the law took effect that talk about all of these companies that were offering health care options to children that no longer are doing it. So now you've denied access to families, parents who had good health care for their kids that don't have that option today.
We have not. The insurance company.
Well, the law did. You personally didn't do it, but Obamacare did. And since it is your job to track these things, I would encourage you to go back and take a look.
Well, we've worked with the states. We've sent guidance out and worked with the states to provide them with options.
Well, you know, and the guidance to the states is, you know, you're on your own now because families don't have the same options.
No,
families had limited options. And you know, I appreciate maybe you have a difference on the overall law. I will say, you know, and I'm glad that the chairman's having this. I'm a little surprised that some of our counterparts on the other side are criticizing us for having this hearing. There's a letter, and I'd like to get the letter in the record. There's a letter that a number of members of this committee wrote last year asking then Chairman Waxman to hold a hearing on these kind of problems, and for whatever reason, Chairman then Waxman chose not to have any hearings, and maybe it's because they didn't want the American people to find out just how devastating this law, Obamacare, is on denying access to people today. Now, one other area I want to get
Do you want to put that in the record?
And I'd like to ask unanimous consent to put that letter in the record, because I think it's important to show we've been interested in this for a long time. Unfortunately, the folks on the other side, when they were in charge, didn't want to have these kind of oversight hearings where the American people could find out that people today are being denied health care that they liked because of this law. Now let's get to these waivers. I think probably one of the biggest heights of hypocrisy is the fact that the president ran around touting how great this law was going to be. It's going to be wonderful for American people. It's going to reform health care problems. Of course, we pointed out back then all the problems it would create. I'm surprised how many people have asked, and now I'm not surprised how many people have asked. Frankly, I think everybody would like and should get a waiver from the entire law, and hopefully the courts will take care of that. But I'm surprised how many waivers have been granted. Can you tell me how many waivers have been granted to companies that said we just, you know, we don't want to comply with some of these sections?
Sure. Through the
I'm running on time. The number. Do you know the number?
I believe the number that we gave you was 915.
Okay, the 915. There's, from what I'm understanding, about 60 companies have been denied that ability to get the waiver. Can you get us the list of those companies that have been denied? And even more specifically, I would ask you to submit to the committee metrics on the number of companies, the number of employees. If you don't want to include their name for other reasons, I can appreciate that, but at least get us the metrics on the number of companies, the number of employees, broken down by region, and also broken down by union versus non-union, because I think a lot of small businesses out there that would like to be exempted from this haven't been given that opportunity, you know, and maybe there's a line formed at the White House where you have to go and genuflect and get it, but frankly, I think it's the public's right to know what those metrics are and to get that data,
sure.
So we can know who has been exempted from this law that was touted as a panacea and is in fact destroying access to health care for millions of Americans. Thanks. I yield back.
Thanks, gentlemen. We're going to go another round of questions. If you would engage us, we appreciate your forbearance here. The president kept saying during his campaign, if you like your health care, you can keep it. He kept saying that as a mantra. But wouldn't both of you agree that without a waiver, these people that you gave a waiver, they couldn't keep their health care? Isn't that true, Mr. Ingoff?
Well, we don't know whether those people like their health care.
No, but I mean, the fact is, the president says you can keep it. You can keep your health care. If you like your health care, you can keep it. But without a waiver, they couldn't keep it. Isn't that true?
They are keeping it. Keep in mind that in 2014...
Mr. Larson, isn't that true, though, basically, that without these waivers, the McDonald's, these people, they couldn't provide...
But I agree with Mr. Engoff. The fact is that they are keeping it, and the ACA contemplated setting up a system to ensure that people in these low annual limit policies could in fact.
Well, you know, the Democrats are continually trying to defend these waivers, but you know what the problem is, the administration, healthcare, Obamacare has created this problem, and now the Democrats are recommending a solution. If they didn't have this problem from the first place, we wouldn't need this solution, which is these waivers. You know, our response on this side is the only reason you have the waiver is because of the new requirements, all these new requirements of Obamacare, making insurance, providing insurance too expensive. For example, you've indicated that you have 915 waivers. 2011, as I understand that the ceiling per year is $750,000 a year. Isn't that true?
That's right.
Okay, and does it go up to 1.25 million roughly in the year 2012?
That's correct.
And it goes up in 2013 to over 2 million. Is that roughly true?
Yes.
So if a person could not